Welcome to the Center Collaborative, Creative Solutions in Behavioral Health and Criminal Justice, brought to you by the Oregon Center on Behavioral Health and Justice Integration, which is also known as the Center. We at the Center are all about solutions. Our job in Oregon is to facilitate improvement of the system so behavioral health and criminal justice can work better together to engage people in treatment while promoting public safety. I am your host, Chris Thomas. I hold a master's degree in clinical psychology and have focused on the intersection between behavioral health and criminal justice for 20 years. Over 7 of those years were behind the walls of a maximum security prison. During this podcast, you will have the opportunity to sit in on real, in-depth conversations with experts about complex topics in a way that is both fascinating and digestible. We will focus not just on what is wrong with the system, but what is going right and how we can work together to evolve. Today's episode is the first of a 2-part series. I am joined by Captain Lee Eby, Clackamas County Jail Commander, and Galli Murray, Clackamas County Health, Housing, and Human Services Suicide Prevention Coordinator. Captain Eby and Galli Murray came together to collaborate around how to improve the suicide prevention program at the Clackamas County Jail. Clackamas County came together and asked, how can we do better? In this first part of the series, we discuss common myths about suicide. We also talk about the collaborative mapping that took place at the jail, as well as data collection. And this mapping and data collection informed the approach of the Clackamas County Jail to improve their suicide prevention program. We talk about the impact of suicide on adults in custody, the staff, as well as the loved ones of the folks who have died. We normalize talking about suicide, and we start talking about the improved screening process for suicide at the jail. In our next episode, we go on to talk about the further steps that Clackamas County Jail and Clackamas County Health, Housing, and Human Services took to improve their suicide prevention program. I learned so much in this conversation. I think you will too. Welcome to our conversation. Today on the podcast, we have Captain Lee Eby, who is the Clackamas County Jail Commander, as well as Galli Murray, who is the Suicide Prevention Coordinator for Clackamas County Health, Housing, and Human Services. Welcome to the podcast today.
Thank you. Thank you for having us.
Yeah, happy to be here.
Today, we'll be talking about Clackamas County's new data-based suicide prevention program at the jail. And Captain Eby and Galli were instrumental in starting the program at the Clackamas County Jail. I guess the first place to start is, what was the catalyst for this program for the jail?
Unfortunately, for us in the jail, it was a actual suicide attempt and success that spurred us into really diving deep into suicide, specifically in our jail, but suicide in general. And that kind of was the start of kind of a long journey, but very informative. And I think really opened our eyes to what we can do in our professions to assist in this issue.
Galli, would you like to add anything to that?
I think I would like to add, there were several options that Clackamas County Jail could have taken after we had an inmate die. And one of those options would have been to do nothing and just to kind of go back to business as usual. And what we know, and perhaps we'll talk about this a little bit later on, but what we know about the risk of folks who are incarcerated is that their risk of suicide for incarcerated individuals is much higher than folks who are not incarcerated. So I really appreciate Captain Eby's leadership around making what were really crucial steps to mitigate risk and to support staff and to support inmates so this type of tragedy doesn't happen again.
I think just adding on to what Galli said, because when we did look at it originally, it was that it's a rare occurrence for a successful suicide in our facility. At the time, that was the second one in 10 years that was successful. So, in a general standpoint, one could say, we're being very successful. We're having very few attempts that went through all the way. And so we could have, as Galli mentioned, easily had said, we're doing a good job. This is just a blip on the radar. Let's just continue what we're doing. And, I have to give credit to not only my staff, but the chief deputy of our sheriff's office, Jenna Morrison, who also pushed to say, let's really look at this. And, the staff being behind it, let's look at it and see what we can do better, or what, if anything, did we miss, so we can learn from the situation.
Attempted suicides or suicides that are completed are incredibly hard on not only the person that it impacts immediately, but folks that are working in the jails, the fellow adults in custody. It's a tragedy whenever it happens. And I'm so glad to hear that that is your outlook as well. Not only the impact on the individual, but the impact on the staff. And how can we look at preventing this from happening, even though we're doing a really good job of preventing this occurrence? How can we even do better? I think is the message that we really need to highlight here. And when Captain Eby, you were telling me about this program, you went about how do we do better in an incredible way. So instead, lots of folks, when they think, how can we do better on any program, they talk a lot about hypotheses, but sometimes they don't go in. A lot of the times folks don't go into the data. They go into what they think will do better without looking at the data. And sometimes those are very different. There is a belief of what will help, but if you go in to look at the data, we see that there's another way that would maybe be more helpful. My recollection is that data-driven prevention is the road that Clackamas County Jail went.
That is accurate. It started off, prior to even looking at that, really with Galli and her team, and obviously looking outside our own expertise and saying, hey, let's find somebody who has specific knowledge and just a breadth of experience in this area of suicide and suicide attempts. And Galli's team was really what started that process, and part of his, and I'll let Galli talk about the process mapping we started with, where we really laid everything out on the table. And part of that was asking questions. And those questions led us to say, we need to look at the numbers. We need to look at this data and find out. But it really was that initial process mapping that really helped us get to where we needed to be. So I'll let Galli kind of talk about how that progressed with the process mapping, what we did to really look at the system as a whole.
Yeah, so the process mapping that Captain Eby is referring to was just an amazing journey. And basically kind of how we set it up was the overall context was that we wanted to better understand current state of essentially what the pathway is for inmates when they come into our jail. So how do they arrive to the jail in the various ways they arrive? What happens along the way? And then how do they exit the jail? And in order to do that, we had to get the people in the room who actually do the work. So I think in a situation like this, it would be really easy for someone like Captain Eby and the undersheriff and other folks who are in leadership positions in the jail to get together in a room and make some decisions about what they think would be best. But what Captain Eby did and the other leaders of the jail was that they were very much in support of gathering the folks who actually do the work. So in the room, as part of the process mapping, we had folks who understand the process of how are folks brought in, like what does booking look like? What happens during booking? How does the jail decide when someone is seen by a medical professional in the jail after they come in versus not? And then what's the pathway? How long are they waiting for a hearing? What happens until that hearing? Et cetera, et cetera. And then how are they essentially released from the jail? Incarcerated longer, or they're released, or they, what have you. And so we had a team of folks that basically walked through essentially kind of the 50,000 foot viewpoint of what is the average kind of pathway of someone when they come into the jail. And, some of the things that I've mentioned. And that, like Captain Eby saying, that really required the team to really think about, okay, well, we ask inmates this question and this question and this question. And then, 5 days later, we ask them this question. And so we literally mapped it out. There was a visual representation of how this looks. And the goal of that was to get it all on paper. And then you have this amazing visual, which is what we're referring to as a process map. And the end result is that you have a really smooth pathway of what happens, and then you can use that to look at, okay, where do we have gaps? Where might we as a system, because part of this work, this work needs to rely not on individuals, but this work needs to rely on a system-wide response. Because if we rely on individuals retire, they get sick, they take vacation, they're no longer there, and we can't do that. We can't rely on systems. We have to have a systemic approach to doing this work, and that's what we created. But so with this visual, we had an understanding of where might we have an opportunity to do it differently. Where might we have an opportunity to be, and this is my favorite part of it, where might we have an opportunity to be more intentional about suicide prevention? And that's the work, is that how do we be more intentional about closing any gaps in our system where, in this case, inmates might be falling through. And then once we understand what those gaps are, then we can say, okay, team, we have a gap right here. What do we want to do about it? That's how we got to asking questions. That's how we got to oh my gosh, this would be a really good idea. And that's how we really kind of figured out where we wanted future state, where we wanted to, which is what exists now, where we wanted future state to exist.
I can say during that process itself, and the team that was gathered not only on our side, but really Galli's side was very diverse, in meaning that there was people from different walks of behavioral health and our county health department to give different perspectives. The first thing, once we laid out this whole map and everybody saw it, the first thing, some of the professionals, especially in the behavioral health, said, oh man, you guys really, there's a lot of points. I didn't realize how many times you're looking at this stuff. And, at first that really brings me joy. I felt proud, yes, we're doing it. But that was short lived, because obviously the next step is, where's those gaps? Where, as Galli says, where can we be? And she said this in the meeting, and I remembered it. And she said today was intentional. Where can we be intentional? And to me, that's where can we focus? And while we had the map, the question still was, okay, what does that mean? Meaning, what are we missing? And that's where we started looking at the data, because the data part of it, we had 2 in 10 years that were successful or completions of suicide. And so 2 doesn't give you a lot of data. It doesn't tell us a lot, unfortunately. And one of the things in our meetings we discussed, and I don't remember who mentioned it or brought it up, was, well, let's look at attempts, because attempts do occur, and they're a larger number than just 2. And that really kind of opened the door to, okay, well, let's do that. Let's look at it. And so from there, we took a 5-year picture, went 5 years back, and took all the data from all those attempts. We also took some data from what in jail realm is called suicide watches or suicide protocols, where people may have hit certain markers during that mapping process that we talked about, where we try to identify them, and we put them in a process where they're closely monitored to ensure their safety and other precautions are taken. And we looked at those too. And so of the 5 years, we found that there was 35 attempts that were not successfully completed. And so that gave us a little bit broader data, and Galli's team and them, and obviously even from my own team, we have a lot of data of suicide in general, meaning overall statistical data across the nation, both in the community and in incarceration. And a lot of our process mapping, our points of contact, as we refer to them, were based on those national, what we knew, right? And so now the idea is, okay, now we know what the nation says. Well, what does Clackamas County say? And in that, what we had found was the demographics. 79% were male that had attempted. We had 21% female, which also is very, very closely mirrors our incarceration population. The interesting thing was 97% white, which is our average population is 86 plus percent. So very high, obviously, white population, but obviously overtly very focused in those attempts were mostly white individuals. The average age was 35, which is interesting. And this was probably the one thing that I think one of the things that shocked me, and I can let Galli also comment on it, but when we get talked about it was historically, the high risk jail populations tend to be, low level, first time offenders, where people come into the system thinking, I have not, my life's over, right? Because it's the worst thing that's ever happened. Well, we had found on all the attempts that we looked at, the average number of jail prior visits, meaning they had been in our facility before, was 10. So most people who had attempted had been there 10 times before. In fact, there was zero. We had found none that was their first time.
Wow, that is really different from the stats you usually hear.
Yeah, it was a different population, and I think shocked us a little bit. I think it made us think, okay, we got to think broader picture here. 73% of obviously the people were nonviolent offenses. Okay, so, and the other thing was the average days from intake, from the day they walk in the jail to the attempt, because this is really important, because we know that first 24 48 hours coming into jail is a high risk time, right? And on our mapping it showed we do a lot. We asked them, I don't remember how many times, but we talked about it. We asked them about suicide ideations, everything, multiple times in that first 24 hours, to the point of almost, ad nauseum. But the reality was the average from intake to attempt was 35 days. And what we saw was a vast majority of that was within the 2 weeks. And so ding, ding, a light went on at that point. So, well, wait a minute, because when we looked at that map that was put together, the thing we saw was, man, we are doing a lot at the beginning. They walking in the door, we're asking them 20 different ways. How are you doing? What's your mental health? But then we noticed the gap. And that gap was really after that 24, 48 hours. Unless something popped up on the radar, such as, they were talking to somebody or we got information that led, we didn't ask them again. And so that again became one of our, as Galli puts it, our intentional points of how we were going to act.
It's a question of there's so much support, it sounds like, in that first 24 or 48 that really supports that individual. And you're doing such a good job in that. And then when that window ends, that's when the difficulties start to occur for that adult in custody. Am I hearing that? Am I clear on that?
Yeah. And I think there, as we know from the system, the charges you're brought in is the first 24, 48 hours, and yeah, that is a very high risk area. And so there needs to be a lot of attention, which we had. But those charges, if they're staying in custody, don't necessarily go away. And in fact, the pressure might increase over time because the reality of potentially prison time or loss of family or loss of social supports create that. And so that was something that we focused on or saw. We also looked at days, times, places in the jail. It was interesting, and I don't know if you see this nationally or not, but it's funny. We had no record of any attempts in the last 5 years in February. Galli, I don't know if you can speak on the national why February, but for whatever reason, we've never seen any.
It's interesting, I didn't know that, when we look at national trends of suicide, not just in our incarcerated population, but just, across the lifespan in the nation, spring is actually the highest period of time where we have the most deaths from suicide. So I'm not so sure about February.
It's interesting that April is one of our highest.
Yeah.
Which goes into that spring.
Yep.
I guess in that sense meets the those national standards.
Yeah.
But just February, for whatever reason, it could be an anomaly or whatever. But it's little things like that we were looking at and really trying to drill down on. One of the other things we looked at too is the average suicide watches, and those again putting people on protocols because of some ideation or other information that leads us to believe that they are at high risk. And on average, our jail, about 307 inmates are placed on that a year. So, and a lot of that is upon intake. The vast majority are, not all of them, but a large chunk. And so we found that obviously that system or that process and protocol for safety was working to a large extent, but the question was why what were we doing with these other 35? How did we miss those? And so that was really where then the more conversation with the group, once we took the data back and really sat down and said, okay, what can we do? And that's where both Galli and her team brought up some ideas or thoughts to try to bridge those gaps. One of them was really looking at, upon intake, is that we asked the brief mental health screener for jails, the national screening process, which was great, works very well. But they brought up trying to do more focused also, and that's where Galli and her team brought up Columbia risk assessment for suicide, which Galli, if you can talk about that for a moment and how that works.
Yeah, happy to. So the Columbia Suicide Severity Rating Scale, also known as the Columbia CSSRS, or the Columbia, is actually a well-used, highly credible screening for suicide risk tool. And there are various versions that are used throughout the world, actually, and there is specifically a version that can be used for the incarcerated population. And so it lands really nicely for our jail team because it's right there. It's something that our hospital systems use, our mental health crisis program uses, our outpatient clinics, both our physical health care clinics and our behavioral health care clinics use the Columbia. And what's really great about the Columbia is that it's a very simple tool, meaning there isn't, this elaborate amount of training that staff have to take in order to administer it. It's actually free. So, a lot of instruments out there, you have to pay for licensing fees, et cetera, et cetera. So the Columbia is free to use for other jails. And even better yet, the training is online and it's free. So again, for folks that are interested in taking the next step to do really, again, being intentional about screening for suicide risk, which is what the Columbia does, everything is literally at your fingertips online. And the training is very short and sweet and to the point. And it's not rocket science to do it. And in fact, that I believe that the questionnaire is really 2 questions that you ask. And if the answer is no, no, I'm not having thoughts about wanting to be dead, or no, I'm not having thoughts about wishing I would never wake up, then you stop. But if the person says, yes, I am, or yes, I did, then you ask a few more questions. I think part of the work of suicide prevention that we need to shift towards, and I'm really pleased that our jail has done this, is we need to be intentional about asking about suicide. So there are lots of other instruments out there, and they're great, but given the risk of folks that are in our jails nationally, given the risk associated for them being suicidal or dying by suicide, we have to be very intentional, again, about saying, have you thought about suicide? Have you ever wished that you would never wake up? And part of what that does is that not only does it catch people who would have otherwise fallen through the cracks if we didn't ask those questions, but it also creates an environment where we signal to other people that this is a place that we're going to ask you about suicide. We don't care if you deny having any struggles emotionally, or any history of mental health, or any, if you don't look, quote unquote, suicidal. It doesn't matter. We're still going to ask you, have you ever had thoughts of suicide? Are you having those thoughts now? And that's one of the ways to close the gap. So the Columbia is a great tool. Great tool.
I have a couple thoughts listening to that. One, do you have the link to the Columbia that you could send me by any chance?
Absolutely.
So when we release this podcast, I'll put the links in for the brief mental health jail screen and for the Columbia, so folks get to that information along with your podcast. So it'll be all in one place.
Awesome.
And then the piece around talking about it. And that is such an important piece to highlight, because I think people get nervous asking about suicide for two reasons that I generally hear. One, that it will put the thought in someone's head. Or two, I'm asking about suicide and I'm opening myself up for liability by asking versus never asking. I'm wondering if you two have any thoughts on that.
I'm happy to start. So you're raising a very long-lasting myth, Chris. So there's this myth out there, right? And not just in the incarcerated world, in our corrections world, that the myth is that if we talk about suicide, that we're going to somehow put the idea into the person's head. That is a myth. That is wrong. That's erroneous. You name it. That is not correct. And in fact, it's just the opposite. What we know is that there's a great deal of research that says that if we ask directly about, are you having thoughts of suicide? Are you thinking about killing yourself? That for a person who is experiencing thoughts of suicide, that they find it a tremendous relief to have someone say, oh my gosh, finally someone is actually saying the word suicide, saying the word killing myself, and finally someone is able to handle what I have been struggling with for months or for years. Because if you think about it, if we can't talk, if we can't say the word suicide, if we can't say the word killing yourself, imagine someone who is struggling with those thoughts, who is trying to find the courage to actually acknowledge that this is the level of suffering they're experiencing, that we have to be able to say it. To your other point is that, one of the reasons why people don't ask is that they're worried about it opening up this door of liability. Other reasons why people don't ask is that, well, if I ask you about thoughts of suicide and you tell me, yes, in fact, you are having them, well, what the heck do I do then? So I'm just not going to ask you, because even though I'm suspecting that you might be struggling, if I ask you, then I actually have to do something about it, which is where training, and we can talk about training, where training comes into play. But, as far as liability, I that's a little bit out of my wheelhouse, but what I can say is that my guess is that we would have a system that can be held more liable if we are not asking about suicide, specifically to a population that we know has increased risk for dying of suicide. So if someone happens to die in a jail and we haven't asked anywhere about suicide, that, in my opinion, would be a significant liability compared to asking regularly and consistently, especially when there's signals that maybe someone is struggling. That feels like it would decrease liability. And again, I'm not a lawyer, I'm a social worker, but that makes a lot more sense to me.
For me, the notion of liability, is what we deal with every day. However, this, even in our conversations, it transcended that to let's do what is right. The Supreme Court has ruled that jails do not have a constitutional obligation to screen for suicide. However, jails don't take that as, oh, then we won't do it. The reality is that the need to do that goes back to what our job is, which is we are to caretakers of those people in our custody.
Would you like to say a little bit more about that case, Captain EB, just to explain that ruling a little bit and give some context?
The Supreme Court case that I referenced was Taylor versus Barks. It's a 2015 Supreme Court case. Barks was arrested in 2004 for a violation of probation. He was taken to a Wilmington, Delaware Correctional Institution. During intake, a nurse who worked for the contractor who provided the health care at their jail conducted a suicide screening based on a model form developed by NCCHC, which is the National Commission on Correctional Health Care. Barks disclosed that he had a history of psychiatric treatment and was on medication, that he had attempted suicide in 2003. so about a year prior to his incarceration. But he stated that he was not currently thinking about killing himself because only 2 risk factors were apparent based on the screening. The nurse gave Barks a quote-unquote routine referral to mental health and did not initiate any special suicide precautions at that time. Barks was later placed in a cell and by himself. He called his wife while he was in the cell and told her that he was going to kill himself. Again, she did not inform the institution. The case shows she didn't call or tell anybody. Again, one of the things that we try to elicit information from those individuals who contact adults in custody in our facility. The next morning, they observed Barks behaving normally multiple times during the morning. And then a little bit later, an officer discovered he had hanged himself with a sheet in the cell. Later on, his wife sues the facility, alleging violation of Barks' constitutional rights to be free from cruel and unusual punishment. Again, by failing to supervise and monitor the healthcare provider, the nurse who had put him on just a normal mental health referral and no special suicide precautions. This was in the Third Circuit Court. They said that there was clearly established that an incarcerated individual had an Eighth Amendment right to the proper implementation of adequate suicide prevention protocols, that he has a constitutional right to that, and that there were material facts disputed by both sides, which is normal for most cases, so nothing unusual there. There was some evidence that was presented by the plaintiffs that the screening did not comply with every NCCHC standard. It then subsequently went to the Supreme Court, who unanimously reversed, finding that the officials were entitled to qualified immunity. No Supreme Court precedent established a right to proper implementation of adequate suicide prevention protocols. The appellate court, obviously in third courts, said that there was a constitutional right. The Supreme Court basically says there was no right existed, nor had there been a case from the Supreme Court issuing that the jail had an obligation to screen all individuals for suicide ideations. Again, the Supreme Court's the one who's basically stating that there was no statutory or constitutional rights that were clearly established that required facilities to create that. In most cases, this is really a legal argument about who has the constitutional obligation to screen and adequately screening, whatever that might mean based on the arguments of an individual. Again, nobody after that ruling, jails didn't all of a sudden throw out all their suicide screening. That did not occur. What it did was set up basically a legal argument about whether or not a jail was legally obligated and constitutionally under legal authority that they needed to provide this type of adequate screening. We all do. I don't know a jail that really doesn't do it in some form. And really, again, it goes back to our professional requirement of care and custody of those people in our facilities. While the Supreme Court may have given that kind of legal out, again, it doesn't really change. It becomes more of a legal argument, as I said, amongst lawyers about who's responsible when somebody dies. And so in this case, the suicide screening process doesn't necessarily make you liable for not having what would be considered an adequate one. You could still be liable for the death. It just, the screening itself may not push you in that direction.
Thank you for the clarification and the context of that case, what that looks like operationally.
And going back to the liability and just the question of doing what's right, one of the things that made it successful, and this was in my estimation, was the notion that there was, when we walked into that first meeting and you have all these people sitting around, and obviously what precipitated this was a successful suicide, was that you're waiting for those finger pointing. You're just sitting there waiting for them to go, man, you guys are horrible. You guys suck. I don't know, what are you doing there? And that never happened. In fact, the opposite. It was more of a very supportive, very, what can we do? How can we help you? Oh, you guys are doing a great job. What can we do to do it better? And that nobody looked down on anybody, is really just coming to the table and, being very honest, as Galli says, is talking about suicide in an honest fashion, not only to those people that we're tasked with overseeing, but just with each other. How can we look at this and go, how can we do better if we're trying to cast, stones at each other about, I'm better than you? Never happened. Never was there one time that said, boy, you guys, somebody screwed up. It was about, what can we do to be better? And I think that's really, that's how you get to be successful.
I would add to what Captain Eby just said that I think that attitude and that approach was instrumental in being able to move the work forward that ultimately moved forward in Clackamas County Jail. That it's easy in our world full of litigation, speaking of liability and blame, especially around the complexity of an incarcerated individual dying from suicide. That is very complex. Suicide is very complex, but having someone die in our jail is extra complex. And it would be easy in our world to look at it from a blame perspective. But here's the deal, is that what fails when an individual dies from suicide, whether that individual is incarcerated or not, what fails is a system. The system has failed an individual. There are gaps in a system that if we can take a closer look and try and evaluate through process mapping, through conversation, through not blaming, but like, what are you doing now? Where are the gaps? Where can we mitigate those gaps? That if we take that approach, that's where partnerships form. That's where movement happens. And that's where risk for incarcerated individuals decreases. And that's why the success of this program that Captain Eby's heading up has been as successful as it is that no one ever blamed anyone because there was no one to blame. And this lended itself for us to figure out ways that we might do it better, differently, and be more intentional. And that's what's happened.
Absolutely. We find that in the work we do around Oregon, the communities that come together with diverse stakeholders and say, it isn't about blame, it's about how do we tackle the problem, are the ones that are really able to move forward, be successful, and do innovative projects. The other piece I really wanted to highlight that I think sometimes gets missed is, Captain Eby, what you said about jail security being caretakers for the folks in their custody. And I think that gets missed. That's another myth I think that happens, is that jail staff don't care about who's in their custody. And this doesn't impact them when that happens. And I know from my work in corrections that is not the case, but is a myth that persists. I was happy to hear you say that because I know that that's the culture that you have at Clackamas County Jail. But I'm wondering if you want to talk about that myth a little bit too.
Sure. And I think there is, perpetrated from movies, from TV, every jail is the Shawshank. And every guard is specific to the ones that they see on TV and how they treat and how they do. And that's not even close to being true. We're professionals. We deal with people. And dealing with people is that we have an obligation to want them to be better than they are when they come in. Part of that is giving them those tools. And as we talk more about some of the steps that we've put into place, some of that is not just while they're in the jail. Some of them we talked about is, how do we do something that is long lasting, that when they walk out the jail, it shouldn't be the county as a whole shouldn't say, okay, we got through it, they got in the jail and they got out and nothing happened. Great. Whatever happens outside is not our problem. And that is not the way we have looked at it as a county. Is we looked at the full picture of what can we do for those wraparound services. The other thing I would mention too is the effect on staff. And in our meetings, that was brought up numerous times. And this is where, again, it's that supportive team. It wasn't brought up by the jail. It was brought up by Callie's team saying, well, how are your staff doing? What can we do for them? Saying it is an impact, and I have seen it, and we see it with staff, is that whether it's an attempt or a successful completion of suicide, there is an effect on the staff, and we cannot just sit by and let that go. We have to recognize it and take steps to assist, whether that's through some type of employee assistance, peer support, or ongoing training. We have to understand that do have an effect on us personally.
I would also just add to that, Captain Eby, that, when we're talking about the impact that a death from suicide or an attempt has on our workforce, it's really important to think about it through a further lens of risk. Folks in corrections, police officers, other first responders have a significant risk of suicide compared to other occupations. It's very significant. And then you add on other risk factors that happen just in life. So maybe you have a corrections officer who is going through divorce. Maybe you have, maybe they're struggling with some mental health issues that they're not discussing. Maybe there's financial troubles. Maybe there's food insecurity. You name it. There may be other things that maybe contributed to their risk. So just as a human being a corrections officer, typically a lot of folk in corrections officer capacity are men. And so we know men have a higher rate of dying than women. And so when we look at their risk as just human beings, right, this is a risky population, right? And then you add in a death from suicide in the jail or an attempt of suicide in the jail, and the impact, like Captain Eby's saying, on not only the employees who were there at the time of the death or there at the time of the attempt, but the larger workforce at hand. Very important for us to recognize that when a suicide attempt happens or a death from suicide occurs, what we refer to as the ripple effect is significant. And oftentimes we think about the family and loved ones of the incarcerated individual who may have died. We think of maybe the individuals who may have discovered the person who died, and then we stop. But what we need to do is we need to expand our understanding of how this impacts the system. That a death impacts many, many layers. It impacts hundreds. Research says that one death from suicide impacts over 100 individuals on some level. And so peer support, EAP programs, checking in on each other, all of that is just crucial for our workforce if we want to keep them A, healthy, B, not burnt out, and C, quite frankly, alive.
Thank you for joining us for part 1 of our interview with Clackamas County Jail Commander Lee Eby and Galli Murray, Clackamas County Health, Housing, and Human Services Suicide Prevention Coordinator. We had so much to talk about that we ended up splitting up this podcast into 2 podcast episodes. Please join us next time as we talk about the program in depth and the changes that Clackamas County made. Lots of them without a lot of impact on the budget, but highly reliant on communication and collaboration. Thank you for joining us today. The Center Collaborative is a production of the Oregon Center on Behavioral Health and Justice Integration, a specialized division of Greater Oregon Behavioral Health Incorporated. It is produced by me, Chris Thomas, with production assistance from Patrick Kennedy. Music by Patrick Mulvihill and Patrick Kennedy. Subscribe to the Center Perspective using your favorite app. To learn more about criminal justice and behavioral health in Oregon, visit the Center's website at ocbhji.org. You can also find us on Facebook. We'd love to hear from you. Please reach out to us. Join us next time as we chat with the experts about programs and partnerships at work within this complex and yet compelling field.